Welcome to the American Journal of Transplantation Journal Club mini-series. My name is Daniel Kreisel. I'm a thoracic surgeon at Washington University in St. Louis, and I'm one of the deputy editors for the American Journal of Transplantation. My co-moderator is Dr. John Greenland at UCSF, who is an associate editor for the American Journal of Transplantation. This is part of a mini-series on T-cell mediated rejection and solid organ transplants, a series that was initiated by Sandy Feng, our editor-in-chief. And journal clubs have already been held for kidney and liver, which were highly successful. And today we will discuss T-cell mediated rejection in lungs. A journal club on heart T-cell mediated rejection will be held in the future. In this pre-recorded session, two papers that were recently published in the American Journal of Transplantation will be presented by the senior authors, Ramsey Hashem and John Belpuria, who are international authorities in the field of lung transplantation. At a future date, a live webinar with an international panel will be held for discussion of these papers. And the two papers we have selected deal with the timely topic of rejection in lung transplantation. As everybody knows, the outcomes after lung transplantation lag behind other solid organs, and alloimmune responses mediated by T cells are an important mediator and risk factor for bad outcomes after lung transplantation. And the two papers deal with new therapeutic approaches, possibly to lung transplant patients, as well as mechanistic insights that lead to conditions that predispose to chronic rejection. The first paper will be presented by Ramsey Hashem at Washington University, and the paper is entitled "A Pilot Randomized Controlled Trial of De Novo Belatacept-Based Immunosuppression Following Anti-Thymocyte Globulin Induction in Lung Transplantation." And this paper was authored by physicians and surgeons from Methodist Hospital in Washington University in St. Louis. The first author is Howard Wang, and Ramsey is the senior author. Ramsey, please.
Thank you, Dan. I should share my screen, I assume. Okay, here we go. All right. Well, thank you for inviting me to give this presentation as part of this Journal Club series. As Dr. Kreisel just said, this is a pilot randomized controlled trial of belatacept immunosuppression in lung transplantation. By way of background, long-term outcomes after lung transplantation are disappointing and remain so, and CLAD, or chronic lung allograft dysfunction, is the leading cause of death beyond the first year after transplantation. DSA are associated with an increased risk of CLAD and death after transplantation. DSA also cause AMR, and the incidence of DSA after lung transplantation is high. So preventing the development of DSA may improve outcomes after transplantation. Co-stimulatory signals are important in T-cell activation. T-cells require two synergistic signals. The first signal is recognition of antigen by T-cell receptor. The second signal is the co-stimulatory signal, which comprises binding of CD28 and CTLA4 on T-cells to CD80 and CD86 on antigen-presenting cells. Without this co-stimulatory signal, T cells become anergic or undergo apoptosis. Belatacept is a CTLA4 Ig fusion protein that binds CD80 and CD86, thereby blocking CD28 co-stimulatory signals. It's FDA approved in the United States in kidney transplantation. And in a large randomized controlled trial comparing belatacept to cyclosporin, belatacept was associated with better patient and graft survival. Importantly, there was a significantly lower incidence of DSA with belatacept in that randomized controlled trial. Yet the adverse event profile and serious infection profile were similar between belatacept and cyclosporin. So our overarching hypothesis that led to this study was that belatacept would inhibit the development of donor-specific antibodies, and that this would reduce the incidence of CLAD and improve survival in lung transplantation. We conducted a pilot study because of the very limited data on the use of belatacept in lung transplantation. And the purpose was to assess the feasibility of conducting a larger phase 3 randomized controlled trial that would examine efficacy and safety. The pilot study was designed to inform the design of this phase 3 RCT beyond assessing feasibility. And by that, I mean that we would estimate an effect size of belatacept on various clinical endpoints. And this estimate of the effect size would be important in power and sample size calculations for the phase 3 randomized controlled trial. Also, this would be important in designing the protocol to enhance feasibility, safety, and efficacy of the phase 3 clinical trial. So we conducted a phase 2 pilot randomized controlled trial at 2 centers, Washington University in St. Louis and Houston Methodist. The primary endpoint of the pilot study was randomizing 80% of eligible patients within 4 hours of completing transplant. Secondary endpoints included enrollment of 50% of eligible patients, retention of 75% of those randomized, and important clinical endpoints, including the development of DSA, death, retransplantation, episodes of acute cellular rejection, lymphocytic bronchiolitis, AMR, CLAD, and infections and other metabolic complications common after transplantation. This is the medical regimen. Patients were randomized 1-to-1 to either the control arm or the belatacept arm, and both groups received methylprednisolone intraoperatively, 500 milligrams. Both groups received induction immunosuppression with rabbit antithymocyte globulin, 1 milligram per kilogram daily for 3 days. In the control group, patients were treated with tacrolimus, mycophenolate, mofetil, and prednisone following a taper with a goal of reaching 5 milligrams per day by 6 months after transplant. In the belatacept arm, patients were started on belatacept on day 0 at 10 milligrams per kilogram and received that dose of belatacept on days 0, 7, 14, 28, 56, and 84. Beyond that, the dose was reduced to 5 milligrams per kilogram every 28 days during the first year after transplant. Between days 0 and 89, they were treated with tacrolimus, and on day 90, tacrolimus was discontinued, and they were started on mycophenolate. And they were treated with steroids from the day of transplant through day 365. This was the prophylactic regimen consisting of valganciclovir for all patients who are at risk for CMV infection, acyclovir for all others. All patients were treated with PJP prophylaxis, and antifungal prophylaxis was based on bronchoscopy cultures. The testing for the study included DSA testing. This was conducted at the Baylor University Medical Center in Dallas, the HLA lab there. And the HLA investigator and the technicians in the HLA lab were all blinded to the treatment assignment of the patients. And DSA was defined as reactivity with an MFI of 2,000 or more. These were the time points that DSA were tested. And they were also tested on an as-needed basis for episodes of graft dysfunction. Bronchoscopy and lung biopsies were done following this schedule that's noted here, as well as on an as-needed basis if clinically indicated. And all pathology specimens were reviewed at the Washington University Pathology Lab by a single pathologist who was blinded to the treatment assignment of the participants. And then spirometry, routine labs, and clinic visits were conducted at the sites according to the clinical protocols. This is the study consort diagram. We screened 107 patients. 49 were enrolled. And among the 49 who were enrolled, 27 were randomized. And 13 were randomized to belatacept, 14 were randomized to control. This table shows the demographics of patients who were randomized. There were no significant differences between the two groups in terms of demographics. The majority of patients were male and white. Interstitial lung disease was the most common indication leading to transplant, and the majority of patients had a bilateral lung transplant. Between January 2nd of 2020, when we randomized the first participant, and May 30th of 2021, 3 participants in the belatacept arm died, whereas no subjects in the control arm died. As a result of this, we halted enrollment and randomization and notified the DSMB and the FDA. We had a meeting with the DSMB on June 3rd, 2021, and proposed that we permanently stop treatment along with enrollment and randomization. The DSMB agreed with that proposal, and the FDA also agreed that seemed appropriate. At that point, all participants who were treated with belatacept were converted to standard of care immunosuppression, tacrolimus, mycophenolate, mofetil, and prednisone. And follow-up was continued for 14 months after randomization. Subsequently, 2 additional patients who were randomized to belatacept died, for a total of 5 patients in the belatacept arm and none in the control arm. This slide shows survival and causes of death. And as noted in the Kaplan-Meier figure, there was a significant difference in survival between the 2 arms. Again, no control patients died compared to 5 in the belatacept arm. The causes of death were variable. There was 1 death from COVID-19. 1 patient died of a restrictive allograft syndrome that developed about 6 weeks after an episode of respiratory failure associated with rhinovirus enterovirus infection. There was 1 hemothorax occurring about 2 weeks after transplant. 1 patient with PTLD died of massive hemoptysis, and there was an out-of-hospital arrest that was thought to be related to possible pulmonary embolism. There were no differences between the 2 groups in the development of DSA, either with an MFI threshold of 2,000 or 4,000. There were also no differences in the incidence of acute cellular rejection between the 2 groups. Of note, there were no episodes of A2 rejection or higher in either group. So all of the episodes of ACR were grade A1. And there were no differences in the incidence of lymphocytic bronchiolitis between the 2 groups. This table illustrates the infections between the 2 groups, and there were no differences in the number of subjects in either group who developed an infection or the number of infections in each group. And the infections are listed here. Most infections were respiratory infections, either bacterial respiratory infections or community-acquired respiratory viral infections or COVID-19. So we conclude that this investigational regimen is associated with increased mortality in lung transplantation, and causes of death were variable, making it difficult to understand why there was an increased mortality. But an impaired immune response to viral infections may be the explanation, although there was no increased incidence in infection overall in the investigational arm. Importantly, there were no differences in acute cellular rejection or in DSA, although we note that the study was not powered for efficacy endpoints. Lastly, this study emphasizes the need for clinical trials in lung transplantation rather than adopting novel treatments based on studies in kidney transplantation or other solid organ transplant fields.
Thank you very much, Ramsey. Our second paper will be presented by John Belpure from UCLA. The paper is entitled Plasma CXCL9 and CXCL10 at Allograft Injury Predict Chronic Lung Allograft Dysfunction. The first author is Michael Shino, and the investigators on this paper are from UCLA, Duke University, Johns Hopkins University, University of Toronto, and Cleveland Clinic.
Thank you, everyone, for the invitation. Hello to everyone, and I'd like to acknowledge all the authors especially from CTOT-20 investigators. CLAD remains the major risk factor limiting long-term survival post-transplantation. Treatment of key modifiable risk factors for CLAD may be the most effective way to improve outcomes for our transplant recipients. Acute rejection and acute lung injury are two of the strongest risk factors associated with the development of CLAD. CTOT-20 is a prospective multi-center observational cohort study looking at risk factors associated with CLAD development. The primary mechanistic aim was to better understand CLAD pathogenesis. With regards to histology, we know that of all the acute allograft injury patterns, and we're talking about acute rejection, lymphocytic bronchiolitis, organizing pneumonia, and acute lung injury, both acute rejection and acute lung injury both involve the recruitment and infiltration of mononuclear cells to the areas of injury. Acute rejection is more perivascular. Acute lung injury has to do with the parenchyma. The chemokines, when we're talking about recruitment of infiltrating mononuclear cells, the two main chemokines that we were interested in were CXCL9 and CXCL10, which are both induced by interferon gamma in a type 1 immune response, and they act as potent chemoattractants of mononuclear cells through the shared receptor CXCR3. Evidence supports the prognostic importance of BAL, CXCL9, and CXCL10 in the risk for CLAD. However, less invasive plasma CXCL9, CXCL10 levels have not been studied to date in lung transplantation. We hypothesize that the injury pattern of acute rejection and acute lung injury will be associated with increased CLAD risk, and this associated will be mediated in part by CXCL9 and CXCL10. And this can be quantifiable not only in the BAL compartment, but in the plasma compartment. So our overall goals were to determine the association of acute allograft injury patterns and CLAD development, evaluate the plasma CXCL9, CXCL10 levels during episodes of acute allograft injury patterns, determine the impact of plasma CXCL9, CXCL10 levels during the injury and risk for CLAD, and compare plasma versus BAL chemokine levels with regards to risk for CLAD. Our cohort involved the first 200 CTOT-20 patients. Just for assessments, 4 to 5 surveillance bronchoscopies were performed essentially on all patients. In addition, there were for-cause bronchoscopies. The primary endpoint was CLAD. With regards to histopathological assessment, it was done by the primary pathologist at each center. And again, the term allograft injury or acute allograft injury patterns really refers to acute rejection, lymphocytic bronchiolitis, organizing pneumonia, and acute lung injury. And the reason for that is many things can happen to our lung transplant recipients, but they all seem to culminate in these 4 patterns. And these 4 patterns seem to be very predictive of CLAD. Infection was also assessed, and we looked at BAL microbiological findings. A pathogen was defined as any organism known to cause a lung infection. Infection was defined as pathogen detection with symptoms, fever, dyspnea, viral prodrome, cough, or sputum. Or signs, radiographic infiltrate, decline in PFTs. Or if the bronchoscopist found purulence in the BAL. It should be noted that we really classified the purulence in real time by the bronchoscopist. It was not retrospective. For our analysis, chemokine differences during the histopathological injury patterns really involved mixed effect models with random intercepts. The chemokines were log2 transformed, and we used MFIs. We also involved covariance from the time of transplant. Greater than 6 months was considered a late biopsy, and we also looked at surveillance as compared to for cause. We evaluated the risk of clad development using time-dependent dichotomous variables. Really what we're talking about there is a way to bring in about recurrent analysis. For example, for acute rejection, you start out at 0 till you get a biopsy. And if the biopsy turns out to be acute rejection, you went up to 1. And you stayed at 1 till the next biopsy. Once it went back to no pathological injury, you went to 0. But if you had another biopsy that showed rejection, you then went back up to 1. With regards to our cohort, ultimately involved 721 biopsies with matching BAL and plasma from 184 lung transplant recipients. 49 or close to 30% developed clad within the 3-year follow-up. 22 or 12% died without clad in that follow-up period. With regards to patients that had clad and those without clad, with regards to baseline characteristics, there was no difference in race, mean age, sex, naive lung disease, LAS scores, induction immunosuppressive therapy, PGD, immunosuppression primary or secondary, or even total number of biopsies between both groups. With regards to bronchoscopic findings, I want to just give you the totals. Again, there was 720 biopsies done. With regards to any allograft injury pattern, that's, again, acute rejection, lymphocytic bronchiolitis, organizing pneumonia, acute lung injury, 26% had at least one of these injury patterns. With regards to acute rejection, it was there in 18% of the biopsies, 13% were A1s, 5% were A2s. Lymphocytic bronchiolitis, organizing pneumonia, and acute lung injury all occurred anywhere from 3 to 5% of the time, and infections occurred in 13% of the cases or biopsies. So overall, the allograft injury patterns occur 26%, 18% are acute rejection, again, 3 to 5% for LB, OP, and ALI, and infections about 13% of the cases. We then looked at plasma and BAL, chemokine concentrations by MFIs. And here, this is descriptive statistical evaluation, looking at a healthy plasma CXCL9 level. The MFIs were 330 for healthies. For those that had allograft injuries, it went up to 428. If you look at acute rejection, very consistent with the allograft injury patterns in the 420s. However, LB was lower, organizing pneumonia up to 414, ALI very high at 505, and a pathogen 377, but true infection, it went up to 473. Very similar pattern for CXCL10, so I won't go through those plasma levels. And the patterns, again, were very similar when you looked at BAL fluid for CXCL9, CXCL10. So overall, you see rises in these chemokines, both in plasma and BAL, when we looked at acute rejection, acute lung injury, and infections. We then did multivariable mixed effects models, were constructed with time from transplant to clinical indication as covariance. And here, we actually did a statistical analysis as compared to healthy. For instance, looking at acute rejection, you see there was a 1.3-fold increase in plasma levels of CXCL9 as compared to healthy controls. So acute rejection and ALI had a fold increases 1.3 to 1.5, both statistically significant. A similar pattern was seen for plasma CXCL10 levels. Both acute rejection and ALI had the highest fold increases, and both were statistically significant. And you can see the range was 1.3 to 1.5 with regards to fold increase. BALs, the fold increases were a bit higher, but not only was it acute rejection and ALI, but also infection was found to have a much higher increase in the chemokine levels in the BAL. And the same was true for CXCL9 as well as CXCL10. So same pattern. So it seems that the BAL picks up infections with regards to rising chemokine levels better than the plasma. With regards to risk for CLAD by histopathologic finding, as you can see, if you have an allograft injury pattern, any of the four, it increases your hazard ratio for the development of CLAD. It was 2.6. You look at acute rejection, was not statistically significant, but trended with a p-value of 0.06. LB was not, OP was not. ALI, of course, was a high hazard ratio of 5 because that's your most severe allograft injury pattern. So of all the variables on univariate analysis, again, acute rejection and LB were the ones that seemed to be the highest hazard ratio. We then multivariable models, and you could see acute rejection then was statistically significant with a hazard ratio of 2.2, and ALI, the hazard ratio went up to 5.9. We then looked at risk of CLAD by allograft injury and chemokine levels. Here we broke it out into quartiles, meaning we took the plasma CXCL9 level, broke it up greater than 25th percentile, greater than 50th percentile, greater than 75th percentile. And you could see with regards to the hazard ratio, there was a dose response going up as your chemokine levels in the plasma goes up, so does your hazard ratio go up with regards to the allograft injury, high level of CXCL9 in the plasma, and the development or risk for CLAD. And this pattern held true for acute rejection, held true for ALI. When we looked at plasma concentrations of CXCL10, we seen the exact same pattern. There was a dose response that goes up. As your plasma chemokine level goes up with the injury pattern, you were more likely to develop CLAD. Again, held true for acute rejection and acute lung injury. When you look at the bronchoalveolar lavage fluid, give you the same exact pattern. So you could see for allograft injury, then acute rejection, ALI. And then we looked at CXCL9, CXCL10 in the BAL fluid and seen the same exact pattern. So overall, you're seeing a dose-response relationship between increased CXCL9 and CXCL10 levels during the allograft injury and CLAD risk. It was a bit more variable with the BAL, and we think that may be due to differences in BAL techniques. We then looked at the risk of CLAD by histopathologic findings and the chemokines and looked for an interaction term. So here you could see when you have an allograft injury alone, the hazard ratio was 1.8, but not statistically significant. If you had a high plasma level of CXCL9, did not increase your risk of CLAD. However, if you had the injury and it interacted with a high plasma level of CXCL9, that was statistically significant and had a hazard ratio or an effect size very high at 3. The same was true for acute rejection. It was the interaction term. And again, for ALI, it was the interaction term. When we looked at the BAL fluid, just to give you a little bit of a difference here, the BAL fluid, the interaction term wasn't always needed. If you had high levels in the BAL fluid of CXCL9, it actually did increase your risk for CLAD, almost met statistical significance. But when you did have the interaction term, the effect size does go up to 3.2. Same thing with acute rejection and the same thing with ALI. Plasma levels of CXCL10 really reflected what we see with CXCL9, and the same thing for BAL fluid CXCL10 levels, reflected very similarly to what we see with CXCL9. We then looked at infections, and you could see infection alone did not increase your risk for CLAD. High levels of CXCL9 did not in the plasma. However, if you did have an infection with a high level of CXCL9, unlike the acute allograft injury patterns, that really didn't lead to statistical significance. And the same thing was true with CXCL10, which was very different when you actually looked at interaction terms with the BAL fluid. The BAL fluid, you had a nice interaction term of CXCL9 with infection. The hazard ratio went up to 2.6, was highly significant. and the same was true for CXCL10, the effect size of 3, so your p-value of 0.01. So in conclusion, you see a strong association between the two allograft injury patterns, acute rejection, ALI, and the development of CLAD. Plasma levels of CXCL9 and CXCL10 do go up when you get these allograft injury patterns, and the higher that plasma level goes up, it does increase your risk for the development of CLAD. There were strong interactions found between the allograft injury pattern as well as the chemokine levels and risk for CLAD in the plasma. Elevated BAL, CXCL9, and CXCL10 levels during allograft injuries. The acute rejection, ALI, increased CLAD risk with similar effect size seen with the plasma. So taken together, both plasma and BAL, CXCL9, and CXCL10 appear to provide prognostic data with regards to CLAD risk. Infection was not associated with CLAD in univariate or multivariate models. However, we have shown with bigger N's that there is an association with specific infections with CLAD. So I really think this has to do with the N size as well as heterogeneity of the various respiratory infections that we captured. It is interesting that infection with an elevated BAL chemokine level, that definitely seemed to be a nice interaction that drove you into CLAD. The BAL compartment may be more preferable with regards to risk stratification, with regards to infections and CLAD development. Larger studies are needed to evaluate the plasma with regards to outcomes for lung transplant recipients because it's non-invasive. Thank you.
Well, thank you. We really appreciate Dr. Hashim and Dr. Palperio presenting your insightful and important work here. Dr. Hashim's paper and the team's work there on Laddicept induction regimens, I think it's really important and provocative results. Even though, the regimen itself seemed unsuccessful, I think completing a trial in lung transplant is an important step. And I think we've got both a major achievement and something that's going to give us a lot of important insights in moving forward in terms of how we're going to design future clinical trials of novel immunosuppression regimens in lung transplant therapies. And Dr. Valperio, your team's work within CTOT is also a really remarkable piece of progress forward and seems to truly underline the importance of adjunctive biomarkers and how we're going to do early diagnostics and targeted treatments for CLAD going forward. So again, we really appreciate both of your team's contributions and the two of you to presenting this work for us. And we're looking forward to our live webinar when we can really discuss these findings in greater detail. So thanks again to Dr. Hashim and Dr. Valperio, as well as my co-host, Dr. Kreisel. Thank you.